Good morning. I would first like to thank the Digestive Cancers Europe organizations for this kind invitation to discuss artificial intelligence and pathology and the impact that artificial intelligence will have on the diagnosis of cancers. As you may know, pathology is one of the cornerstone of modern oncology, as it allows to make a definitive diagnosis from, for example, biopsy samples. It also allows to assess the prognosis of a particular tumor and then to adapt the treatment. What do we do in pathology labs? So we receive the tissue fragments, either from biopsy or surgical resection specimen, and we will cut this tissue fragment and we will make stains on this tissue fragment. And these stains will allow us pathologists to investigate the histology of the sample, the histology of the tissues. It's the way the cells are arranged together. And also we look at how the cells look. And this reviewing, this investigation allows to make a diagnosis of cancer or a benign condition. And it also allows to assess the prognostic features of the cancer and to adapt the treatment. So these sections are put on a conventional glass slides that is routinely reviewed using a classical conventional microscope. You have an example here of a histological picture of a liver cancer. So it has been stained with different regions. So the nuclei of the cells appear dark and the cytoplasm pink, and you can identify, the tumor cells in the tissue. And we produce every day several hundreds of slides that we investigate, that we review to make accurate and definitive diagnosis of cancer. So each day we work on conventional glass slides with a classical microscope. This is likely to change in the coming years, because since approximately 1 or 2 decades, there have been some device that allows to scan this conventional glass slide into a digital file. That means that we don't need a microscope anymore. We have a file and in a particular format, and on a computer, on our screen, we can review the slides. So the slides are encoded in a complex format. I won't go into too much technical details, but we really can investigate the slide just as with our microscope at different magnification. And this is due to particular properties of these digital files. This digitalization of histopathology is really interesting. For example, for teleconsultation, you can ask the opinion of an expert on a particularly difficult case. For example, you can send these files via, of course, internet, and there are some cloud platforms that host such slides. But maybe more importantly, it will change the way we review and we study the slides, because when you have this digital file, you have like a very large picture, and you have to remember that an image, a photograph, and every image is a matrix of numbers. Each number is the value of the pixel, and also there is a spatial coordinates for each pixel. You have here an example, the same example, the histological micrograph of the liver cancer. So it's a color picture. So like photograph, it is encoded in RGB. That means you have, for one image, 3 different matrices of number, one for the red, one for the green, and one for the blue. And the image will be the sum and the addition of all these matrices. As I mentioned before, the advent of digitalization is really a revolution for pathology, also for medical imaging, because, as I said, it's very convenient if you want to ask a second opinion, but more interestingly, probably, you can process mathematically these images, which are encoded as matrices of numbers. And you can apply different mathematical processing to have a more robust, a more standardized assessment of the images. So what do we use to mathematically process these images? We use artificial intelligence and, in particular, deep learning. Deep learning is a particular technology of artificial intelligence that relies on the use of convolutional neural networks. It's not only used for medical images. For example, when Facebook or social media application automatically recognize your face in a picture and tag you, they use this kind of approaches. And these convolutional neural networks have been designated with this name because they are thought to mimic the way the brain works. I won't go into too much technical detail, but basically what are they doing? They extract numerical values that are thought to represent the different characteristics of the image based on the matrices of numbers, and they will process these values, and they will learn what are the important values that will predict, for example, a particular feature. For example, you give to the model images of cancer that were highly aggressive and images of cancer that were not aggressive. And the architecture, the neural networks, will learn what are the characteristics within the image that allow to predict the aggressiveness of the cancer. And you can predict basically whatever you want: the gender of the patient, the age, the molecular alteration, the mutation of some genes, and so on. And you have here an example of a study that we performed in liver cancer. We investigated a patient who had hepatocellular carcinoma and who underwent resection. We digitized the glass slides of the cancers, and we process these slides by this mathematical architecture to predict the prognosis of the cancer. And we did this because we think that it's very important to predict the prognosis, because it's the way to adapt the treatment and to give maybe more aggressive treatment if the tumor is itself more aggressive. And so we did this on approximately samples of 200 patients. And you have here the results. So just very briefly, these little boxes indicate the performance. You have here the boxes of the models of deep learning that we trained using these numeric slides. And these are the clinical, common clinical features that are used on a daily practice to predict the aggressiveness of liver cancer. And what you can see here is that these boxes, they are above those ones, so they perform better for the prediction of survival than the common features that we use in daily practice. These are the survival curves of the patient according to this prediction of the model. I won't go into too much detail, but briefly, the model validated well the prognosis of these cancers. What is also very interesting with these technologies is that they allow to review the slides and indicate you where are the features most indicative of prognosis. For example, you make a prediction of prognosis in a liver cancer. The model tells you this is a very aggressive cancer. Then you can go back to the slides and to see what were the cellular types that were highly predictive of a wrong prognosis. So you can generate new hypotheses. For example, the model tells you that in an area with a particular cell, for example, cells with fat in the cytoplasm of the cell, this is associated with an adverse prognosis. Then you can make additional studies investigating the role of intracellular fat in the prognosis. So it allows to generate new and disruptive scientific hypotheses. Also, a new and a rapidly evolving field is the development of artificial intelligence-based biomarker on digital slides. I told you can predict prognosis with these kind of neural networks. You can also predict genetic alteration. You know that for a certain number of cancers, we can investigate the genetic alteration to give particular treatment. For example, in colorectal cancer, if a tumor has a particular phenotype that we call microsatellite instability, we are likely to give immunotherapy to the patient because we know it is highly efficient for a patient that have this kind of tumors. And there is a team in Germany that has trained neural networks from digital slides to automatically detect this particular phenotype without the need to extract the DNA, to perform the molecular biology experiment. You know, it's very expensive. It takes a long time. So now, just in a few minutes, by the processing of the digital slide, you can predict this particular phenotype. And so it could really reduce the cost of screening and also allow to screen more patient and more rapidly, and to avoid a misclassification. So, of course, it's a very interesting field, and I think that we need now to validate this kind of approaches of biomarkers by prospective validation, and we need to assess their performance, their accuracy with really rigorous methods. I think that the biomarker field will be more likely to be rapidly implemented in clinical practice because there are other teams, other scientists that are trying to make automated diagnosis, like to replace the pathologist. But in this case, you won't tolerate any error, so it's a difficult field. And then all these approaches, and it's true for pathology, but also for everything else, they question the relationship that we'll have with these models and the degree of confidence that we have in these models. So I think they will not replace the pathologist, but I think in the future we will have like a composite assessment by the pathologist and also by the neural networks. And maybe the pathological process in the near future will look like that. You have, for example, a pathologist, you receive a surgical specimen of a colorectal cancer, you perform your assessment, and then you order particular artificial intelligence-based diagnostic or prognostic modules. You can detect, for example, metastasis in the lymph node using these diagnostic modules, and you can predict the genetic alterations, predict the prognosis, and then at the end you have a composite report, pathological report. You have the conventional diagnosis and the conventional assessment by the pathologist, but you have also the predictions that are performed by the model, for example, for the molecular alteration or for the aggressiveness of the tumor. I would also like to end by saying that models sometimes can go completely wrong. For example, on Google there is a website where you can upload a picture, whatever picture you have, and the model will try to make predictions. So, for example, I took this picture of a liver, and I uploaded it in the Google website, and the prediction was it corresponded to a restaurant in Mexico City, although it may be a really nice restaurant, but it was not the picture I gave the model. So you see there, it's it's a joke, but it's to show you that you can go completely wrong with this kind of model, and you have always to be cautious. Again, I would like to thank the organization for this invitation, and to thank all my collaborators from the hospital and also from the research teams. Thank you.